All right. Good afternoon, future nurses. We are now going to start talking about dysrhythmias. I hope that you have a good grasp on reading normal rhythm strips because understanding normal is really just so important to being able to understand abnormal. So now we're going to start talking about abnormal. So we've gone through our questions for, is it normal sinus rhythm? Is there a QRS for every P wave and a P for every QRS? Are the PR interval and QRS complexes within normal limits? Is it regular, and is the rate between 60 to 100? So if the answer is no to one of those, what is missing? What made it not normal? So then we're going to look at, where is the problem happening? How is it affecting our client? What is happening inside their body because of that alteration in the electrical rhythm, and what are we going to do about it? So let's get started. Do you guys remember this strip we just looked at the end of the last presentation? We determined it was sinus bradycardia. So looking at that strip, we're going to say, look at it and say, what is wrong? So what's wrong with that strip? Why is it not how we want it to be? It's too slow. The heart is not pumping fast enough. So that is going to be the first issue we look at. We're going to look at sinus bradycardia. So what is happening? All of the pieces, remember there are 4 questions, everything's there. We've got our normal complexes. If we measured them out, our PR interval and our QRS are within normal limits. It is regular. What we don't have is a heart rate that is between 60 and 100. Our heart rate is less than 60. So that is what's creating sinus bradycardia. I'm just going to point out this term sinus that we use when we're talking about sinus rhythm, sinus arrhythmias, sinus bradycardia, sinus tachycardia. That sinus, when we use that term, we're saying that it's coming from that sinoatrial node. So it is a normal beat. That's what we're calling it. Each of the beats are normal. They've got the pieces they need. They started in the sinoatrial node and they're normal beats. Each beat is normal. So then we go off of that and we say sinus bradycardia. So it's a normal beat, but there's not enough of them. Sinus tachycardia, that's a normal beat, but there's too many. Or sinus arrhythmia. So that would mean that it's a normal beat, but they're not marching out regularly. So we'll look at all these little pieces. So first up, let's talk about sinus bradycardia. We know with sinus bradycardia, as I said, it's orienting itself in the SA node, so it's a normal beat. But what we are going to talk about with every type of arrhythmia is going to be how it affects cardiac output and how that is affecting our client. So let's first talk about causes. What are some things that can cause sinus bradycardia? In some people, we may see that it is just a lower metabolic need. If you are not needing extra blood pumping, sometimes with a lower metabolic need, like when you're sleeping, athletes that are in really good shape typically have a lower metabolic need, and so that their normal resting heart rate is going to be lower. Hypothyroidism is also a situation where we'll see a lower metabolic need. Other things when we see a sinus bradycardia is that vagal stimulation we talk about in other units, but that bearing down and pressing down on the vagus nerve, it can happen with vomiting. If you're suctioning your patient, with severe pain, somebody may be bearing down with severe pain, and having a bowel movement may also lead to that vagal stimulation and cause a sinus bradycardia. Also, an inferior wall MI may cause, or heart attack may cause a sinus bradycardia. It might knock out some of that blood flow that's going to that primary pacemaker. And then also medications. Remember, we give a lot of medications for people for their heart. Some of them are going to lead to a lower heart rate. beta blockers, all those things that you have to count an apical pulse and you don't give for a heart rate less than 60. Guess what happens if you have too much of it? It's going to cause sinus bradycardia. So beta blockers, digoxin, narcotics can lead to bradycardia as well. Diltiazem is used to control heart rate, and atrial fibrillation can also lead to a lower heart rate. So those calcium channel blockers. And then if in hypothermia, whenever that body temperature gets very low, you have that lower metabolic need. So that also leads to bradycardia. You will also see it with elevated potassium levels. So what is that going to do to our client? What is that going to do to the body? The bradycardia affects cardiac output because there's just less beats, right? So it decreases cardiac output. And so thereby it's going to decrease your arterial blood pressure. Less beats, less pressure in the arteries. So we're going to talk about this more, but the signs of a decreased cardiac output. Think about all those things we've talked about in all these units leading up to this. There are signs and symptoms of decreased perfusion, decreased cardiac output. So syncope, dizziness, low blood pressure, hypotension, diaphoresis, confusion, lethargy, decreased level of consciousness. These are all going to be signs and symptoms of a decreased cardiac output. So these are going to be the things that we're going to be assessing for. And we are going to talk about treatment in just a minute. So before we start talking about treatment of bradycardias, here's a few other slow things to think about. These are blocks. You do not need to memorize these. Put your pencil down. Do not, I can highlight this as many times as you need me to. Do not, let me change color so I can make it stand out. Do not memorize these. These are not to be memorized. They are not going to be on NCLEX. They are not going to be on your test. But I just want, slow is slow. Decreased cardiac output due to a slow rhythm is going to look the same. So I just want to bring them to your attention because it's some of the things, I just want to kind of look at them in that we've looked at the normal way that the electricity flows through the heart. And so I just want to look at them to show you how if you understand the normal, that you can understand what's happening on these. I'm going to change back to a nice red color again, maybe yellow. So with this first strip up here, if we went through our steps of looking at the normal of the, is there the P wave for every QRS? Yes, there is. They do march out and they're regular. The QRS complex is within normal limits. This one looks like it's a little bit slow. But other than that, the big one here we're going to see is that there's a really long PR interval. That is a lot more. This would be about 5 blocks right here. So that would be your max. And it's a lot longer than that. It's a lot longer than what our normal break is. So if you think about the normal anatomy and the normal electrical rhythms in the heart, what we've got is here at the beginning of your P wave, you've got your SA node firing. If you remember, this PR interval represents the amount of time. Here's where this P wave is representing your atrial contraction and the electricity going through your atria and then getting to the AV node right here. So here's your AV node. And we know your AV node holds on to that electricity before it sends it onto your ventricles so that both chambers of the heart aren't beating at the same time. What's happening with a first degree AV block, that's what this is called, is that it's an AV block. There's a block in the AV node. It's not conducting as quickly as it should. There's a block there. So that's just kind of what I wanted to show you, was how, if you understand normal, you can understand what's happening inside there. basically, this isn't really dangerous unless the heart rate gets low, but what we know is that it may lead to further blocks, to second-degree blocks and third-degree blocks. So second-degree blocks, I'm not going to go, there's two different types. I'm not going to go into them because I don't want you to get confused. But one, your P wave gets long, your PR interval gets longer and longer until you drop a beat. And one of them, you have a normal beats, and then you'll just have a missed beat. So sometimes if you think about when there's these missed beats, this P wave means that that electricity has gone through the atria and got to the AV node right here, and then it just stopped. Nothing happened. And then the SA node picks back up and starts back up with a normal beat. And then lastly, if that progressed, you would see these third-degree blocks down here. I feel like you could look at these, as we've looked at so many strips at this point, I feel like you can look at these two and understand that's bad. Those are bad. You've got a major disconnection between that SA node at the top of the heart and the AV node in the middle. There's no connection between the two. They're not talking to each other. So those are bad. So I just wanted to bring those to your attention just to kind of show you how, if you understand normal, you can kind of see what abnormal is. The other thing is that they're slow. They're slow rates, so we're going to treat them similarly to sinus bradycardia. So let's look at treatment. So when we talk about treating our clients who have a pulse, this portion of our going through the rhythm strips, we're going to be talking about how to treat people with a pulse. The next presentation is going to be about treating people without a pulse. So right now, when we're talking about treating people with a pulse, we are always going to start with, how does the client feel? Are they symptomatic? And I'll tell you why. We talked about some reasons earlier why somebody's heart rate might always be slow. They might have a lower metabolic need. If you've got a athletic person whose normal heart rate might be 36, how do you know that you don't need to treat it? Is based on how they feel. If it is not impacting their cardiac output, then we're just going to monitor them. If you've got somebody who's got an alteration in rhythm that is affecting their cardiac output, that is when we are going to know that we need to treat it. This is affecting their cardiac output and their perfusion to the rest of the body. So that's how we know when we're going to treat. If somebody is confused and diaphoretic and pale, anxious, nausea, dizziness, any of those things, that means they're symptomatic. And the other terms that we'll use is stable or unstable. So we might say a patient's a stable sinus bradycardia. So that means they're asymptomatic, blood pressure's good, they feel good, all is well. But you might have might say they're bradycardia, unstable bradycardia, meaning there's something, their cardiac output is compromised and we need to fix it. So what are we going to do? This is your adult bradycardia algorithm. We go by the American Heart Association. I'm circling down there at the bottom. With the American Heart Association, those are the guidelines we follow. Some other companies use other guidelines. Our gold standard is going to be the AHA and the American Heart Association. They put out new guidelines every 5 years. Guess what we've got? Brand new guidelines. If you are not used to using these algorithms, I would encourage you to get to know them. They are your friends. They are your guidelines. They are going to be, you are going to need to be familiar with them and know the information on the algorithms I give you. You are going to need to know them for testing purposes. Okay, so it is your guideline. You will have access to them during simulation and things. You'll have your algorithms to go by. Obviously, you will not have an algorithm to go off of during the test, but so you need to be familiar with the algorithms. So first up, assess appropriateness for clinical condition. So that's when we're talking about that is this what is expected for this person, or it's not going to be abnormal for this person. That's going to, and this heart rate typically 50, less than 50 is saying that typically a heart rate, even though normal is 60 to 100, between 50 and 60, you're rarely going to have somebody who's symptomatic, who's got symptomatic bradycardia between 50 and 60, very rarely. It's usually below 50. So next up, the very first thing that we're going to look at is treating the underlying cause. So always treat the underlying cause. What could be causing this patient to be bradycardic? Can we fix it? Can we fix it quickly? Is that going to make it, and can we, because if so, then we don't necessarily need to go past that. So are they breathing? Are they hypoxic? We're going to go ahead and get IV access and get a 12 lead if we are able to. Don't delay therapy, meaning don't sit around and wait till you can get a 12 lead. If your patient is symptomatic with their bradycardia, we are going to go ahead and treat them. We're not going to sit around and wait to see what happens while we're waiting for a 12 lead. So consider possible hypoxic or toxicologic causes. Remember we talked about medications, narcotics being a good, being one of those things that are a lot of times what's going to have put your client at risk. If your patient comes in or you're caring for somebody, you know they've got a cardiac history, what's the chances they're taking a beta blocker or digoxin or a calcium channel blocker that could have slowed them down? Is your patient confused and was taking their own medication at home? These are things to think about. So next up, is that bradycardia causing hypotension, altered mental status, signs of shock, ischemic chest discomfort? Remember, lack of perfusion can also show that, lead to the heart muscle perfusion may be compromised as well. And remember also, MI was one of our things that we talked about could cause bradycardia. So are they having chest pain with it? That could lead us to what the cause is as well, or any acute heart failure. So these are all our signs that we've got decreased perfusion that we talked about. So that is what this is asking right here. Is your patient symptomatic? Is their cardiac output compromised? If the answer is no, look what we're going to do. Monitor them. We're not going to do anything aggressive to somebody who is not symptomatic. So all these patients up here, this is our first thing. Our patient came in with a heart rate 30. So we've gone through all these things to look for the cause and get them hooked up, get them a monitor, get a 12 lead if we need to. Now, what does their cardiac output look like? What do their symptoms look like? Are they fine? Okay, well then we're not going to do anything aggressive. We're just going to monitor them because their cardiac output is not compromised. If it is, the first thing we're going to do is we're going to follow our little arrow down the chain here. And that's the way these algorithms work. You go through bubble and you follow the arrow away from it. So if our patient had a blood pressure of 85/40 and was confused, we're going to pop on down to what do we need to do next. The first thing is atropine. Over here on the side, we have our doses for your atropine. First thing we're going to do is we're going to give 1 milligram bolus, IV bolus of atropine. We are going to repeat that every 3 to 5 minutes for a max dose of 3. So we are going to, that's going to be the first thing we're going to do. Give atropine. Going to give a milligram, wait 3 to 5 minutes, see if we get an improvement, 3 minutes. If your heart rate's 30 and you're having cardiac output issues, we're going to wait 3 minutes. Then we're going to give another dose. If it's starting to come up, we may wait a little closer to 5, but if your patient's still symptomatic, we're going to give that other dose. We've reached our max dose. So now we are looking at atropine is ineffective. So what are we going to do? We are going to do transcutaneous pacing. I'm going to talk more about that in just a minute, so just hang tight on that. I'm going to stick onto here for right now. The next slide is going to be about transcutaneous pacing. So the next thing we're going to do, we can start that or we can do that in conjunction with or give a dopamine infusion or an epinephrine infusion. And the doses for those are down here. Dopamine infusion, initial rate, we're going to do 5 to 20 micrograms per kilogram per minute is the way it is dosed. Titrate to patient response and taper slowly. So you're following these explicit instructions here. We've got dopamine, we're going to start at 5. We'll turn it up every couple minutes if we don't see a response. And then epinephrine is the same. We also have down here at the bottom, and we just went over it, but we've got down here at the bottom different causes for bradycardia, right down here at the bottom of our algorithm. Isn't this algorithm just amazing? I love the algorithms. It's one of the reasons I love cardiac. It's like you just follow the rules, follow the instructions. They tell you what to do. So down here we have our causes that we have gone over. So up here, identify and treat underlying cause. In case we're feeling flustered, because sometimes you feel flustered in an emergency situation. Hopefully you don't. Hopefully you keep your calm because you learned all this and you know what to do. But in case you didn't, that information is right down here at the bottom of your algorithm. Lastly, after we have hopefully gotten the patient's heart rate under control, but if we still haven't, we are going to consult an expert. We want a cardiologist. We want an expert to come in and say, what do we need to do next? And then lastly, transvenous pacing, which we will also get into here in just a second. So that is your adult bradycardia algorithm. As I said, you need to know your algorithms. Print them off, make flashcards off of them, study them. All right, so we have here transcutaneous pacing. So I'm gonna be going through a couple more slides here as we talk about this. So these are your defibrillator pads, right? You hook them up, you can put them anterior lateral. So anterior lateral is going to be that right upper chest wall, and then basically where the like V5, V6 went when we talked about your V leads down like anterior axillary, mid axillary line down below the heart. So when you're placing defibrillator pads, that is the pathway that energy is going to travel through. When you place them, that's where it's going to go. So you want them on each side of the heart. Most of the pads actually have pictures on them and have like a picture of like a person's chest and have like the picture of it. Like this needs to go here, and then has a picture on this one as well. That's a chest. That makes it look a little bit more like a chest. And then it'll have like a picture of it on there. So you know which one goes where. But remember, that is making an electrical pathway. So you want them to kind of be on both sides of the heart so that it's traveling directly through the heart. So you can do anterior lateral. You can also do anterior posterior, which is what we see here. So right on the front of the chest, right on the front of the heart, right smack in front of it, and then sandwiching it between. And this is going to improve your conduction, but it does take a little bit more time to flip your patient. Okay, we have a quick video to watch about transcutaneous pacing, and then I will continue.
Transcutaneous pacing is a life-saving procedure for a significant bradydysrhythmia. It is indicated in the setting of hemodynamically significant bradycardia that is unresponsive to medical treatment. It is contraindicated in the absence of hemodynamic compromise or if the patient is responding to medical therapies. In the setting of PEA arrest, cardiac pacing is rarely helpful and should only be considered in the first 10 minutes after arrest. The anterior electrode should be placed just to the right of the sternum, and the lateral electrode should be placed in the mid-axillary line at the apex of the heart. Open the control door and power on the monitor. Activate the pacer function. set the desired pacer rate. Finally, increase the current until you see electrical capture on the monitor. Electrical capture is denoted by pacer spikes consistently followed by wide QRS complexes. Mechanical capture of pacing beats should follow electrical capture. This is confirmed in feeling an increase in the palpable pulse rate. If transcutaneous pacing fails, or if there's a prolonged need for pacing, consider transitioning to transvenous pacing.
Okay, so as the video said, hold on, I'll turn my video back on. So as the video said, whenever you don't do this for somebody who's hemodynamically stable. So if your patient is asymptomatic, please do not hook them up to a monitor and then shock them every beat. They're not going to like you very much if you do that to them. Also, it is after you've gone through the medications, the atropine, and then started either a dopamine or epinephrine drug before you're going to start this transcutaneous pacing. It is not super comfortable from what I've heard. As I said, you're shocking. You're giving small shocks to create heartbeats. So what you'll do on your defibrillator is set it to pacemaking mode, and then you'll go increase your milliamps until you get capture. So as that video said, capture is going to be when you start seeing these pacer spikes. You're going to see the pacing spikes. You're going to keep increasing, right? This one's at 35 milliamps. So they've continued increasing. So you know that you have reached the correct milliamps. You're going to slowly increase because you don't want it more than what it needs to be either. Like I said, uncomfortable. So what you'll see is then when every pacer spike is followed by a QRS complex, then that is when you know you've got capture. If you've taken care of a patient who's had a pacemaker, we're going to talk about permanent pacemakers also. But if you've taken care of somebody who had a permanent pacemaker and maybe looked at the heart monitor, you probably have seen these spikes. But we're going to talk more about permanent pacemakers coming up. So let me clear my drawings and go to the next slide. So if that transcutaneous pacemaking is going on for a very long time or is ineffective, they can also try a transvenous pacemaker. So with the transvenous pacemaker, it's going to be done invasively. They'll run a wire through either the, this one is showing the right IJ or internal jugular or subclavian, and run that wire down into the right ventricle. And it'll work the same way. It'll put out an electrical impulse and encourage those beats. So that, and cause those beats to happen, cause that electricity to happen. What's happened is that this SA node isn't doing all it needs to, so it's going to get some extra help. I've also seen these, you'll see them get put in a cath lab sometimes, and they might be going through that through the leg as well and coming up. Let's see, there is a video here you can watch on your own time if you're interested that just shows transvenous pacemaker placement. So if you see continued problems and it is not something like, say, medication that has caused the bradycardia, the persistent symptomatic bradycardia, then it is something that is wrong with the heart's own pacemaker. So the SA node or the AV node, there's been possibly the MI that's caused damage to that area of the heart or something like that that's knocked out the body's own pacemaker, then your patient may need a permanent pacemaker placement. So there are two different types. You may have a single chamber pacemaker, which would go into the, as you see in the diagram here, they will place it, the permanent pacemaker piece just under the skin, and then run the wire or the lead down through the from the left subclavian vein down into that right atrium and then into the right ventricle. And what you'll see the pacer spikes just before that QRS complex. You'll see one pacer spike just before the QRS complex on the rhythm strip. You may also see a dual chamber pacemaker, which is what we have here. It has two leads. It's also called an AV sequential or dual chamber pacemaker. So same thing, that pacemaker is placed just under the skin, and then they are going to run the wires and the leads, one into the right atrium and then one down into the ventricle. So that is going to be a dual chamber pacemaker. When you have a dual chamber pacemaker, you have two spikes. We've got a spike here and a spike here. You're going to have two spikes with each beat, one for the atria and one for the ventricles. So you'll see one spike, and then it's usually not a normal looking P wave, but a P wave nonetheless. We can see it a little better on this lower view. And then the QRS complex following the second spike. All right, so let's talk about our nursing care of taking care of somebody who's had a pacemaker placed. So as I said, they'll be put in usually in an electrophysiology lab or cath lab. They just make a little slit, slide it into the pocket, and then run those wires via x-ray. They'll do an x-ray while they're doing it so that they can see where those wires are placed. So this would be a dual chamber that we're looking at over here. So most of today's pacemakers are made to protect, and they are not affected by electrical interference. So old pacemakers, you might have heard people say that they couldn't use microwave ovens or sewing machines, and different things like that because of the electrical interference. And that is no longer an issue. People who have pacemakers can use the microwave. They can use razors. They can ride in a car and operate a car, and none of it affects the pacemaker. They may want to take care to avoid anything with high-powered motors. So for that reason, while our normal household appliances and cars and things are okay, things like high-powered CB radios or welding machinery or radar devices may interfere. So they don't want to come in direct contact there. The pacemakers, typically, if a patient has a pacemaker, they're going to need to carry an ID card with them if they go to the airport, because it will set them, it may set the metal detector off. It also makes our clients who have pacemakers ineligible for things like MRI imaging. So no MRIs. If you have a pacemaker or internal defibrillator, which we'll talk about in a second, either of those, no MRIs. So they'll need to make sure that they let their healthcare providers know. So immediately post-placement, let's talk about caring for our client post-placement. There's also a care of a patient with a pacemaker information in LMS, loaded in LMS as supplement material you can look at. So after having that pacemaker placed, things we're going to think about is going to be the risk for infection. Remember, it's going to be anytime when there's a break in the skin, we've got a risk for infection, and this is no differently than any other surgery. Going to watch the patient for the risk of infection there at the site. We're also going to watch for bleeding at the site. Remember, they went into a blood vessel. So bleeding, you may see bleeding outside, but you may also see, if one of the complications you may see would be bleeding happening inside. So if they're starting to have pain, pressure, things happening in that shoulder, in that left shoulder, you are going to want to be aware of that. So we will, one of the things that we'll do is put the patient's arm in a sling. Left arm goes into a sling to prevent those from dislodging those wires. So whenever someone first comes up after having a pacemaker, we want to put the left arm in a sling and keep it there for 24 to 48 hours to protect that side from getting those wires dislodged or causing any bleeding or trauma to the site. For that first 48 to 24 to 48 hours while we're settling over there, we're also not going to want to do a blood pressure or IV sticks on that arm for the same reason. We just don't want to be jostling it around. So as I said, the patient could think, as far as monitoring for bleeding, it could be bleeding there from the site, or it could be third spacing and accumulating into that third space. So if bleeding is suspected, we need to call the cardiologist who placed it immediately. We may want to remove the dressing and look at the site to see if we can see any pressure, and then we'll put a pressure dressing on top of it. If we suspect bleeding, then we may elevate, and especially if it's like going into the arm or anything like that, then we may want to elevate that arm after all, but only in that instance of bleeding complication. If that's happening, we'll want to do neuro checks on that arm. Is pressure going into that arm and causing a problem? And the cardiologist will need to address that issue very quickly. Next up, we've got implantable defibrillators and also external defibrillators. So if you have a patient, this is typically what we see is patients who are at high risk for life-threatening arrhythmias, like ventricular fibrillation or ventricular tachycardia, which we will talk about in the next presentation. But these patients, typically people who have very low EFs. If you remember talking about echocardiograms with Ms. Hurley in 114, I believe, and looking at that decreased ejection fraction, if you've got somebody with an EF of less than 20, then they're going to be at risk for VFib or FTAC coming on. So these patients may be fitted with an internal defibrillator. So it is, it looks like he's got an NG2. Let me clear my drawings. Okay, so these can also work with pacemaker. They can also serve as pacemaker and pace the heart. But what they will also do is monitor the cardiac rhythm, and then if a shockable rhythm, which we'll talk about in the next one, VFib or FTAC, is sensed, if it sees that that's going on, then it will deliver a shock to save that patient so that they're not going into full cardiac arrest for an extended amount of time. And then sometimes there may be a wait for them to be able to have their ICD implanted for different reasons. Sometimes it's just that possibly they were on blood thinners and they have to let their blood flip over to not being anticoagulated. They have to let those medications clear their system before they go through the invasive procedure. Could be any number of things, getting over an acute illness, anything like that. So in that case, we do have external cardiac defibrillators. LifeVest is one of the brand names that's more popular that they can wear that serves the same purpose for a temporary time until they can get their permanent defibrillator placed. So typically anymore, patients do not have to go into, because most of those pacemakers and everything, they're going to record rhythms over a long period of time and keep up with if there's anything going on. And so used to, people might have to go in and get them checked or read. But nowadays, I really don't understand how it works, but it does. They can use a telephone and hold the telephone up to their chest, and it sends the signal to the companies, and they can look what's going on. So if your patient has a pacemaker, and things like if they're starting to have some of those symptoms of decreased cardiac output, then they may call in their call in their pacemaker company so that they can read them and see what's if there's anything going on there. One of the things to think about is pacemakers are set to a certain rate. When you've got a permanent pacemaker, it's set at a certain rate, 60, 70, whatever they have it set at. So the patient's heart rate shouldn't drop any lower than that. Their pulse should not be any lower than that. So if you've got somebody with a permanent pacemaker and their heart rate is, and it's set at 70, and the patient knows that it's set at 70, but they started feeling bad and they checked their pulse at home and it was 45, you've got a problem with your pacemaker. There's something wrong. It's not doing what it's supposed to do, because their heart rate, their pulse shouldn't drop lower than what their pacemaker is set at. So a couple things that can happen is failure to capture or failure to sense. Our top one here is going to be failure to capture. Down here we have failure to sense. So failure to capture is going to happen when the heart is not responding to the pacemaker spikes. So you're not having a QRS complex after every single pacemaker spike. We're missing. So our pacemaker spikes are marching out regular. They're set rate, they're doing their thing, pacemaker's pacing away, but not every single one is leading to a QRS complex. These are missing their QRS complex. So that's a failure to capture. Failure to sense happens when the pacemaker isn't picking up on the heart's beats. It's when their patient is having beats on their own, which just because you have a pacemaker doesn't mean you have beats on your own. Some people, we say they're 100% paced or they're pace dependent because they do not have any beats on their own. But that's not true for everybody. Some people just have spikes here and there, and the pacemaker just kicks in when they get down below where it needs to be. So failure to sense happens when the person has some beats on their own, but the pacemaker is not picking up on that. So where you'll see that is like here, this pacemaker has shot off right after a T wave. This pacemaker shot off right after the QRS complex. See that? So it should be, it's not sensing the patient's own heartbeat. So here we've got a patient that's putting out their own heartbeat, but the pacemaker is not sensing those beats, and it's just like throwing out spikes, throwing out spikes. So that is what we call failure to sense. So that is it on pacemakers and bradycardia and treating bradycardia. So next up, we're going to move into some other arrhythmias. So a couple things that we'll see is going to be a PAC, so a premature atrial contraction. PAC is happening when the atria is contracting a little earlier than what it should be. So here, let's look at, this is a normal QRS complex. This is a normal QRS complex. We've got P wave, QRS, T wave, P wave, QRS, T wave, and on down the line. Over here where we see these PACs, what we see is P wave, QRS, T wave, but before the ventricles have had time to go back to their relaxed state. So remember that T wave represents ventricular repolarization, or the ventricles returning to their normal state. And we have, before that has happened, we have an atrial beat. We have that atria firing up a new shot. So like this one is normal atrial beat, and then this one's early. So that's what we call PAC. Typically not dangerous at all. It may be sometimes if people feel like their heart skipped a beat, then this may be the cause of it. It may be a PVC also. We'll talk about in a little bit, but not right now. But so this could be the cause. It can be, PACs can be caused by caffeine, alcohol, nicotine. If your atrium are stretched, like in a hypervolemic state, you're in fluid volume overload, that could lead to it as well. Sometimes even just anxiety. Hypokalemia, low potassium levels, can lead to it as well. Also, if there's some sort of an infarction or injury to that cardiac muscle. Anything less than 6 of these a minute is typically okay. It's going to be about figuring out what's causing them and treating that underlying cause. And they, just like PVCs, we'll talk about in a little bit, a lot of times it has to do with how is it affecting the client's quality of life. If they feel like their heart's racing all the time, or they're feeling it's making them anxious, then maybe that anxiety is causing more PACs. So then they may try to dig a little deeper, but typically there's going to be a cause and we're going to look for it. It could also be a sign that AFib might be coming. So we'll be talking about that shortly as well. But atrial fibrillation, it could precede. Increased PACs may be a predecessor to atrial fibrillation. So we talked a little bit ago about sinus arrhythmia. Just briefly, when I was talking about sinus, means that it's a normal beat coming from the sinoatrial node. With sinus arrhythmia, what you've got is normal beats. It's got all the pieces it needs to have. Rate is within normal limits. Here we've got a rate of 60. We've got a normal PR interval. We'll go ahead and measure it just for fun. It's going to be from this line here over to this one here. So we've got 4 small blocks. Remember, 4 small blocks. 4 times 0.04, it's going to be 0.16 for our PR interval. Our QRS complex is going to be about 2 small blocks, so 0.08. What we don't have is that it is not regular. We've got a big gap here, medium gap. So it is not regular. Most patients with sinus arrhythmia, that's what makes it sinus arrhythmia. It says we say yes to all the other questions except for is it regular? And it's a sinus arrhythmia. Most patients are asymptomatic. If your heart rate is normal, it's not affecting cardiac output. If it's not affecting cardiac output, it's unlikely that your patient's going to notice the signs and symptoms or that there's anything going on. So most of these patients are asymptomatic. All right. Next up. Ooh, what do we have here? So you guys may know if you have, I bet you've taken care of a patient with this before. So let's look. Do we have a P wave for every QRS and a QRS for every P wave? We've got QRSs, but I don't know what all this is over here. Is this P wave? Is this P wave? What's P wave? What's happening there? I don't know. Let's just leave that one. That doesn't look like P wave. Next up are the PR intervals, the QRS complexes within normal limits. Well, if we don't know what the P wave is, we can't really measure a PR interval. But it looks like our QRS is about 0.08, so it's within normal limits. Let's just keep looking. Is it regular? No, not even close. All right, not even close to being regular. And what's the rate? Right now, we got a 6-second strip. We got some 6-second tick marks here. 1, 2, 3, 4, 5, 6, 7. I don't know that I would count that. Beat is on the other side of that line there. But 70, 75. We can count it as a half a beat for right now. It's 75. But typically, we're going to only count what's inside of our lines. When we count, leave it inside the lines. This QRS complex is just outside of our line, so we're not going to count it if we're just going off of our 10-second strip, 6-second strip. Okay, so not regular. The rate is good. We just don't know about that P wave. So what do you think this is? Atrial fibrillation. So I bet even if you didn't know what was going on, I bet you have taken care of a patient with who is in atrial fibrillation before. So let's talk about atrial fibrillation and what it does to your cardiac output. First up, let's go back to our anatomy and looking at what's normal and abnormal. So remember that very first piece of your normal complex is going to be your P wave. Well, what we have here is just some chaotic movement, right? We've just got this weird little fibrillation. So we've just got basically, remember your P wave is your atrial beat. We don't have a firm atrial beat. What we've got is fibrillation of the atria. So just like jiggling, like jello, it's just moving around, nothing organized, just disorganized disorganization, just wiggling, jiggling around. So a couple things. First of all, what's that going to do to our cardiac output? How's that going to make our patient feel? Well, for this person here, they've got a ventricular rate of about 70 to 80. So probably if they're just sitting on the couch not doing anything, they may feel fine. They may not feel symptomatic. They've got a normal ventricular rate. At the same time, without your atria giving their firm kick of blood into the ventricles, you lose that atrial kick. That's part of the back and forth process that the heart likes to work off of. What you've got is jiggling up here, and this lower part just, it's hard to do two different things with my hands. And so you don't have as much force as you would when your heart beats just doing what it normally does. So that atrial kick accounts for about 25 to 30% of cardiac output. So when you lose that atrial kick, you also lose 25 to 30% of cardiac output. So that's quite a bit. So if this person gets up to get off the couch, then what they might feel is short of breath, nauseated, weak, all those things that we see with decreased cardiac output. Here's the other thing that we need to think about. We've got atria jiggling. They're not squeezing blood out like they're supposed to. So what's happening to that blood that's in there? It's just being swirled around, right? Some of it's getting down into the ventricle, right? Some of it is, but not enough to have a good kick. So a lot of it's just swirling around in there. And that swirling can lead to clots, which leads us to the biggest risk factor with people with these AFib and AFlutter, which we'll get to in a second. Biggest risk is going to be thrombus formation and clot formation in those atria. If they get, and let's go back to our anatomy. So remember, if a clot formed in the right atria, where would that go? I'm going to give you a second to think about it. Pause it if you don't know, because you need to think through. So if you've got it in your right atria, it's going to go into your lungs and cause a pulmonary embolism. Now, if you've got a blood clot in your left atrium, where's it going to go? Chances are the big risk is that it's going to go to your head and lead to, it's going to go out the arterial system, and it can lead to a stroke is the big risk with atrial fibrillation. So all of our patients, most of our patients who have AFib are going to be on anticoagulants for that reason. So back to AFib. So let's talk about this atrium and what they're doing. They're quivering, right? So that atrial rate could be upwards of 300 to 600 times a minute that those atrium are firing off. That SA node's like, blah, blah, blah. So here we've got at the beginning of the QRS complex, so we've got some normal QRS complexes. The beginning of these QRS complexes is when the SA node fires off to the ventricles, right? So they're getting some response from the top, and then they're firing. It's like, maybe everyone, let me keep this normal. But sometimes what you have is called maybe atrial fib with RVR. So that would be AFib with rapid ventricular response. What happens when that's happening is that, remember, that atrial is 300 to 600. So that AV node isn't filtering as many beats out. And so it's ending up that those ventricles are rapidly responding. And so you've got a rate of usually like over 120, but could be like up 200. So that is what, when we talk about AFib with rapid ventricular response, that is what we were talking about. So let's look at what's next for our disorganized atrium. So atrial fibrillation, disorganized is disorganization. The atria, remember your P wave reflects the atrium. So AFib, atrial disorganization. It's going to be irregularly irregular. So no keeping up. It is about never. The only reason usually AFib is regular is if somebody's got a ventricular pacemaker keeping it regular. Typically, AFib is never a regular pace because there's not ever a regular electrical current going down that normal pathway. So let's look at atrial flutter. Atrial flutter. What we have here is, where's our P wave? Is this P wave? This P wave? This P wave? Could be any of those. So there are all kind of P waves. Instead of fibrillating, the atria are kind of fluttering. It's more of an organized rhythm, but it is still not normal, right? We still don't have P wave, QRS, T wave. What we have is just the atrium are just fluttering. So they are not going to completely empty. So you're still going to be at risk for that coagulopathy, and you need to be on, they'll need to still be on anticoagulants. So typically, though, with a flutter, it has this sawtooth pattern. The P waves, it is very easy to tell what it is because it is a clear sawtooth pattern that is going on, that you see where you're looking for your P waves. That rate is going to be 200 to 400. So a little bit slower than atrial fibrillation, but still not where we want it to be at. Still not an organized, good atrial kick to support those ventricles. So you get these flutter waves. And now with atrial flutter, sometimes it's irregular, but a lot of times with atrial flutter, you'll still be able to march these out and have a regular rate. Not always, but that is one thing that can help you distinguish between AFib and A-flutter. AFib, not regular. A-flutter usually is, I'm not going to say always though, because it's not always, but a lot of times it is. So sawtooth pattern is going to be your trademark with atrial flutter, and then with atrial fib, it's going to be this completely disorganized pattern. All right, so let's talk about those atrial dysrhythmias, AFib and A-flutter. Risk factors with AFib and A-flutter are going to be the same. So basically, risk factors, one is going to be just increased age. It's one of the reasons that you see, we'll probably have taken care of somebody who has atrial fibrillation, that it with increased age puts you at risk. High blood pressure, diabetes, valve disease, heart failure, obesity, increased alcohol consumption, hyperthyroidism, cardiac ischemia or inflammatory disease in the heart is also going to be things that they are at risk for, or things that put them at risk for AFib and A-flutter. So signs and symptoms, as I said, sometimes they may be asymptomatic. Otherwise, you're going to have those same type of low cardiac output type of symptoms: shortness of breath, sometimes chest discomfort, dizziness. You may have hypotension with it as well. Another thing to think about, we talked about the big risk is going to be blood clots forming. But if you have AFib or A-flutter, it also puts you at increased risk of other cardiovascular disorders, like heart failure, MI, valve dysfunction, and like a dilated cardiomyopathy. Remember, those ventricles are having to work harder because they don't have the atria collaborating with them for optimal beats. All right, so last up, what are we going to do about it? What are we going to do for treatment? Let's check it out. So one of the things that we'll do is a cardioversion. So with a cardioversion, we are going to basically shock the heart back into rhythm. So when you use the defibrillator and you defibrillate somebody who's in a lethal arrhythmia, it is high energy and it's not organized in the way of when it shocks your heart. There's no organized beats happening in the heart, so it just shocks. With cardioversion, we want to deliver specifically on the R wave, or after the R wave, excuse me. So we want it to deliver right on the R wave, like right on the back side of it. Where's my pencil? There it is. Okay. So we set it to synchronous. We set the defibrillator to sync. This is very important. If somebody has a pulse, you set it to sync. If you don't, then you may put them in cardiac arrest. So if they have a pulse, anytime you shock anybody that has a pulse, you need to have the sync button selected on the defibrillator, and it will defibrillate on just after the R. Just after the R wave. So we'll talk about defibrillators more, about them being biphasic or monophasic. If it is a monophasic defibrillator, the energy just passes in one direction, from one pedal to the next, or one pad to the next. If it's biphasic, it goes two directions. So you don't need quite as much energy to reach the same effect. So also with cardioversion versus defibrillating, you use much lower energy levels. Typically, you may start at even as low as 50 joules or 100 joules. And then you may have to increase if your patient isn't responding and going back into a normal rhythm. We're going to watch this in a minute. I'll show you a video in just a second of a cardioversion. So important information for if you're doing a cardioversion. Your patient needs to have been in atrial fib or atrial fibrillation for less than 48 hours. So we're going to specifically, if your patient is asymptomatic and in AFib, we have no idea how long they've been in AFib, right? No idea. Could have been in forever or for weeks. Who knows? We're not going to shock them because remember that blood's just been jiggling around in there and possibly built up a clot. If we shock somebody's heart and it has a clot in it, guess what we're going to do? Probably dislodge that clot and have it shoot out into the bloodstream places we don't want it to go. So if it's been over 48 hours, or they don't know how long they've been out of rhythm, then we will need to anticoagulate the client first. The other thing we may do is a transesophageal echocardiogram prior to cardioverting. So you learned about, we've talked already about some about echocardiograms. So the ultrasound of the heart to look at the chambers of the heart. So you can have that as that outside ultrasound, or you can have it as a transesophageal. And in that case, it goes down into the esophagus and takes ultrasound images from the inside out. And the reason that it is necessary to do a transesophageal echocardiogram instead of a regular echocardiogram is that in your left atrium, there is a little pocket. It's just a little pocket in there. It doesn't serve a really good purpose. It is called the left atrial appendage. But what it does do is collect blood clots if you're an AFib or a flutter, even more than the right atrium or the rest of the left atrium. That left atrial appendage is a great place to collect blood clots. So that is why when you hear people talk about AFib, the biggest risk being a stroke, that instead of it being they're just as much at risk as for having a PE. The reason they're more at risk for the stroke is because of that left atrial appendage, little pocket collecting blood. So you can't see that on a regular echocardiogram. They can't see that left atrial appendage. So they have to do a TEE to be able to look into that left atrial appendage and assess for any blood clots if they're going to go ahead and cardiovert. So that would need to be done first if they're going to cardiovert without anticoagulation and they've been in AFib for either an indeterminate amount of time or more than 48 hours. So we're going to talk about some medication therapy in just a minute. We're just going to keep talking about cardioversions for just a second. If you are cardioverting someone, we're going to use the mnemonic, "Oh, say it isn't so." So we want to have, oh, look, it's like my underlines were in the right place already. That's awesome. So we want an O2 sat monitor. They're going to probably be under sedation with analgesics if possible. So we will need an O2 sat monitor, suction equipment. If you're going to do something that's going to make somebody sleepy, please have something just to clear their airway as well. IV line, intubation equipment in case they are oversedated. So we just want to be on the safe side. If we're treating somebody with a AFib that we're going to cardiovert, we want to have oxygen and a sat monitor, suction equipment, IV, have intubation equipment available, and sedation if we can. All right, so some other things that we can do to treat AFib or a flutter. Ablation therapy is a treatment in which a catheter is put into that right atrium, and basically they try to, so with the AFib or the A-flutter, you got all these electrical pathways just firing off all over the place. So they're going to try to find where that disorganization is happening and burn it or freeze it, and basically stop that erratic firing. They're going to try to get to the pathway that's causing all the chaos and kind of kill it off so that the rest of the pathways can go back to a regular rhythm and do their job. So we will watch a video about that. And then we've also got video of cardioversion.
It was doing bad. I was just getting weaker. I mean, I couldn't do nothing.
Our Lasithia ward is one of more than 2 million Americans living with atrial fibrillation, or irregular heartbeat, the most common type of heart arrhythmia. This progressive disease is often undiagnosed, with symptoms so severe, many people can't live a normal life.
And I would be doing nothing and sitting still, and my heart rate would shoot right up.
Atrial fibrillation occurs when the electrical impulses in the heart are disrupted in the atria, the upper chambers of the heart, causing it to contract abnormally so that the normal sequences of the heart's electrical impulses are short-circuited. The result is an irregular heartbeat in which the heart can't pump blood effectively.
Atrial fibrillation is a rhythm abnormality that people get where their upper chambers of their heart beat irregularly and chaotic. And that can then drive the bottom chambers, which are the main pumping chambers of the heart, to beat erratically as well, often very fast. Sometimes people will have both slow and fast rhythms, and that generally causes significant symptoms to the patient.
At Sentara, highly trained Sentara heart cardiologists are treating atrial fibrillation with a procedure called cardiac ablation. Ablation uses radiofrequency energy to create a lesion or blockage on heart tissue, which disconnect the misfiring impulses. The end result is a normal heart rhythm. During a cardiac ablation procedure, a long, thin, flexible tube is put into a blood vessel in your upper thigh or neck. This tube is called an ablation catheter. It's then guided to your heart through the blood vessel. An X-ray machine provides images of the heart during the procedure to help the doctor accurately position the catheter. A special machine then sends high-frequency energy through the catheter to the heart. The cardiologist guides the energy to small areas of the heart tissue where abnormal heartbeats may cause an arrhythmia to start. The energy destroys small areas of heart tissues, creating lesions. These lesions block the misfiring impulses and restore normal heart rhythm. Cardiac ablation procedures are minimally invasive, and so recovery is fast. Most people are able to leave the hospital the same day and resume normal activities within 24 hours.
I feel much better, and I don't have that shortness of breath, and I just feel great. I feel great compared to what I was feeling.
For more information on cardiac ablation or other state of...
In this video, we're just going to see what it looks like on the monitor. On the next one, we're going to see a patient actually go through the procedure. Put it on sync, 50 joules. That didn't do it, so they've got it on sync still. And up to 100 joules. Still no. There we go. A good normal sinus rhythm. Okay, so this next video is an actual video of somebody having a cardioversion.
So we're going to be doing a cardioversion here. We have an atrial flutter going on. So this is our patient. We're going to blur her face. But can you tell me a little bit when this... she just made an interesting face there. But when did your heart start beating fast? Yeah. About 11:15 today. All right. And you were, and tomorrow you were actually going to get an ablation procedure.
Correct.
All right. And so you were taking off your medications and
Waiting on the procedure to begin.
okay. All right. So in a minute we'll be doing that. We're going to do propofol. Are we all set for the procedure sedation?
We are.
And you understand this will be on YouTube, but your face will be blurred. So. All right. Now we actually have the pads on your chest already. Do you mind being on? Okay. What voltages are we going to use?
We're going to do 50 joules.
50 joules. Okay. All right.
So I want to stir that. Is that
Our cardiologist is standing here at the bedside, leading and directing this procedure. Do you have any words of wisdom?
One learning point is we like to tuck in patients' arms gently.
Oh,
So
good
their
point.
arms, when they're cardioverted, don't bump up. Minimizes the risk of hand or finger injury.
Oh,
Side rails.
very good point. Okay.
Tuck you in snugly.
All right.
Not too snug. To help prevent the fingers
Popping up.
You'd be surprised. Yeah.
Okay. Anything else you do?
You have to make certain the patient has an ED recently. Obviously, this is an urgent indication. It's very early this morning. You got to make sure you have all the appropriate stuff to support our airway nearby when you do deep conscious sedation like this. And be ready and prepared to record her rhythms after she cardioverts so you can document her post-cardioversion rhythm. And sometimes we cardiovert people from atrial fibrillation to atrial flutter, and then they require more cardioversion. So it's important to see what the strips are after the cardioversion itself, even if they remain intubation.
Okay. And then how do you put your pads on? Is this anterior, posterior?
This is a typical anterior posterior location. Occasionally we'll do side to side. Okay.
And that tends to work best as far as you're concerned?
It depends on the body habitus, but
okay.
For someone with her type body habitus, this is a very acceptable pad location.
Okay, suction's ready. Airway equipment's all ready. All right, end-tidal CO2 is on.
Working on that one.
Nursing staff, do you mind being on YouTube or? No. Okay. Oh, no. You're all gorgeous.
Yeah, I wonder where the credit card is.
We got plenty of crash cards.
The whole room's a crash cart.
All right, here we go. It's game time, sleeping time. Jessica, tell me what you're doing as far as your.
We got her 1 milligram per kilo.
Okay.
When do I start the burning? Any moment. You may be one of the lucky ones that doesn't burn. Just feels full. What? One more? I'm gonna give you 20, and then I'll be leaving.
Cycle or blood pressure for you real quick.
Just cycle it.
I did. That doesn't make any sense.
How you feeling?
Getting sleepy? I think she's.
Okay, everybody ready? Clear. So 50, Frank.
50, sir.
Charging to 50, everybody clear.
Sarah, clear.
Go.
Got it.
Converted.
Sign row. Thank you.
She's out.
Cycle or blood pressure. Make sure. There you go.
Heart rate. 100%.
82. Yeah, good idea. There you go.
Take a little oxygen.
Okay, so hopefully those visuals helped you to kind of understand that the cardioversion. So let's talk about medication management. Remember that anybody who has AFib or a flutter is going to be at risk for stroke. So they will do a stroke risk assessment to determine if they need to be on anticoagulation. If they go on it, it's probably going to be long term. So risk factors to add to if they have AFib or A-flutter, other things they'll look at is if they have CHF, high blood pressure. Oh, I'll turn my video back on. CHF, hypertension, if they are over the age of 74, diabetes, if they've had a prior stroke or a TIA, that's going to put them at risk. If they have vascular disease, that will also put them at risk. So they may put them just on medication just to control their rate. Cardizem may convert, but it also may just control their rate and keep it slow. Same with digoxin and beta blockers. Remember, we talked about that with AFib, people who aren't super active may not have any signs and symptoms with the AFib as long as their rate is controlled. So as long as their rate stays in a normal range. So they may just use medications like cardizem or digoxin or beta blockers to keep that rate under control. Now, there are medications, these ones that are at the bottom, that flecainide is a really common one, Ticasin, Rhythmol, amiodarone, or Corvert. These are all medications that can be used and can convert. They're PO medications that can be used long-term, but they can also convert from AFib to a normal rhythm. So if with Ticasin, for instance, or flecainide, any of these that you're going to use as conversion medications, the same rules are going to apply as far as that anticoagulation piece we talked about earlier with the cardioversion. Just like you don't want to shock somebody's heart if they've got a blood clot in there, the simple act of the heart going from this to this could throw a clot as well. So we want to make sure that there's no clots present if we're going to give medication that's going to cardiovert. Also, some of these medications can impact the EKG and can prolong that QT interval. And that's just going to be a problem if it gets too long and it's running into the next cardiac cycle, if that T wave gets out so that the P wave's coming into it, or it's causing a bradycardia because it's stretching out. So sometimes when these get started, they have to be on cardiac monitoring to begin with and may only start them in the hospital too. And that's going to be client dependent. All right, so we've got a new strip. So we've talked about our atrial dysrhythmias here. So let's look at this strip here. We've got a pretty good looking strip. Let's go through our check marks here, all the things that we want to look at. So is there a P wave for every QRS and vice versa? It certainly looks like it is. All the complexes look like good normal complexes with the P wave, QRS, and T wave. Is the PR interval and the QRS within normal limits? So let's look. Here's from here to here. It's going to be 1, 2, 3, 4 spaces. So 4 times 0. Remember, the small spaces are with 0.04 equals 0.16 for our PR. And normal was between 0.12 and 0.20. So we are good. QRS, let's see here, it's going to end about right here. So we've got 1, 2 blocks. So that's going to be 2 times 0.04, which is going to equal 0.08. Normal for QRS is less than or equal to 0.12. So we are good there. So that is also normal. Is it regular? If we march this out, we would find that it is in fact regular. And then lastly, what is the rate? So we don't have any tick marks. So we're going 1, 2, 3, 4, 5, 1, 1, 2, 4, 2, 1, 2, 3, 4, 3, 1, 3, 5, 1, 2, 3, 4, 6 second strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We've got 12 QRSs in our 6 second strip. So 12 times 10 from our 6 second strip is going to put us at 120 beats per minute. So is that between 60 and 100? It is not. So what is wrong with it? It is too fast. So let's talk about tachycardias. All right. Sinus tachycardias. Remember, we talked about sinus tachycardias are going to be the ones, it's going to be a tachycardia, so over 100, that's starting in the SA node at the top of the heart. So if we look back to our last rhythm we had here, each of our complexes is normal. It's got, each of them have this P wave that is starting at the top of the SA node and making its way down just like a normal sinus beat. So that is what makes it sinus. We've got sinus tachycardia because it is too fast. Some causes for sinus tachycardia could be physiologic or psychologic stress. So it could be an increased demand on the heart, exercise, acute blood loss is going to be something that, because if there's less blood flowing through your body, your heart's just pumping, 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 trying to get it everywhere it needs to go. So you'll see it with blood loss, anemia, with shock, because the fluid is not where it needs to be at. And so same thing, your heart's trying to get it where it needs to be. You may see it with either fluid volume excess or fluid volume deficit. So with any kind of alternate fluid volume levels, you may see at heart failure. If somebody is in pain, you will see an elevated heart rate. Hyperthyroidism, just like bradycardia was associated with hypothyroidism. If you have a fever, you will have an increased heart rate. Exercise, anxiety, or if that fight or flight response has been stimulated, then you will have an elevated heart rate and sinus tachycardia. There are also some medications that can lead to sinus tachycardia. Stimulants. So if somebody's had atropine or epinephrine, some of the medications that we give for other things like dopamine, aminophylline, also bronchodilators, albuterol is one that you see people's heart rate racing after they've had some albuterol treatments. Stimulants like caffeine and nicotine. And then also illegal drugs like amphetamine, cocaine, and ecstasy can lead to tachycardia. So let's talk about what does tachycardia do to cardiac output. So with cardiac output, with a really elevated heart rate, what you're going to see is that your stroke volume is going to be reduced because there's going to be not enough time between all these beats. You're not going to have time for proper filling of the ventricles. So what you're going to see is that stroke volumes decrease, so you're going to have a decreased cardiac output, decreased ventricular filling, and preload is going to lead to a decreased stroke volume and cardiac output. So we're getting ready to look at our tachycardia algorithm. I know y'all been dying since you looked at that bradycardia algorithm. You've just been dying to see another algorithm. So we're getting ready to look at another one. So things to think about real quick before we go into it. Whenever we're identifying our tachycardia as sinus tachycardia, we're going to look at things that are less than 150. If the heart rate is over 150, we're typically going to call that SVT, or supraventricular tachycardia. The reason for that is because when you get up over 150, you can't typically, truthfully, determine what the inherent rhythm is. So if it is going so fast, over 150, it's going to be hard to identify if it's really AFib or if it's a flutter, that if it's an AFib with RVR, a flutter with RVR, or if it's a sinus tachycardia. So anything over 150, we're just going to call it SVT. And we'll talk more about that in a minute. So let's look at our algorithm. So we've got a client that is in a tachycardia. See, this just says tachycardia. It doesn't name what it is. It just calls it tachycardia. So with this, it says it has this 150. Do you remember in the bradycardia, it had less than 50? And that is just a general guideline because typically, same as with the bradycardia, you're typically not going to have somebody that's symptomatic that's between 50 and 60. Oftentimes, you're not going to have somebody symptomatic that's between 100 and 150. A lot of times, that 100 to 150 is going to be a warning time for us that we need to figure out what's going on so we can take care of it, but not necessarily that our patient is symptomatic at that time. If they are symptomatic, we're still going to try to treat them. So, up next, so that's what it says typically. If your patient's symptomatic, we're still going to treat them. So, first up, identify and treat the underlying cause. So figure out what could be causing this AFib. We talked about medications and stress, fever. We're going to look at if the airway is patent, if they are hypoxic. We're going to look at getting them on a monitor, getting IV access, 12 lead if available. So this step is the same as it was with the bradycardia, correct? We've got somebody that's tachycardic. We're going to see if we can figure out what caused it. We're going to get some oxygen on them if they need it. We're going to get them hooked up to a monitor and get an IV in. So that's going to be the first things we're going to do. Now, we're going to get into the nitty-gritty meat and beef and potatoes down here. So first thing we're going to look at, is it causing, remember all these things we looked at before? Hypotension, altered mental status, signs of shock, chest discomfort, acute heart failure. Are any of these things present? If not, if our patient's just sitting there and it's like, I mean, I understand you're telling me my heart rate's 170, but I feel fine. Okay, well, let's look on down here. We are going to look at if it is a wide complex QRS, and it tells us what that means. So even with a tachycardia, we can still measure that QRS complex if that QRS complex is normal. So 0.12 or if it's less than 0.12. When you've got a rate that's super fast, that QRS should be a little bit smaller. So when you're looking at a tachycardia, if it is less than 0.12, then it is a narrow complex tachycardia. Narrow complex. If it is less than 0.12. If that QRS complex is greater than or equal to 0.12, it is a wide complex, wide QRS, okay? So we're going to say it's no because we're going to keep on with our no's right now. We're going to go down here to no. It is not. So what are we going to do? Vagal maneuvers. First thing, have your patient bear down. Have them breathe through a straw. Have them bear down like they're having a bowel movement. I've seen it work before. It does work. We're going to talk about adenosine in a minute, so I'm not going to talk about that. We can try a beta blocker or a calcium channel blocker, and we're going to get an expert consultation. Okay, but this person feels fine, but you know, their heart's going to get tired if it's going 170 for the next, it can't continue this way, or it'll get tired. That muscle's going to get tired. So we need an expert to tell us, what are we going to do next? What are we going to do to try to diagnose what's going on with this person and fix it? All right, so let's go back up to this, that we still have a stable person. They still do not have any kind of signs and symptoms of decreased cardiac output, then, but they do have a wide QRS. What are we going to do then? We are going to actually, you know what? Let's don't talk about this right now. We're not going to talk about this right now. I'm going to talk to you about it in a little bit when we talk more about wide complex tachycardias. So I'm going to get back to that actually. But for right now, if they have a narrow QRS or normal, so within normal limits, normal QRS, it's not wide, it's narrow is normal, narrow normal. Then we're going to do vagal maneuvers, possibly adenosine. I'm going to talk about that in a minute. Beta blockers or calcium channel blocker, and expert consultation. So let's get back up here to now to that our patient is unstable tachycardia. They've got they're hypotensive, they're confused, they're having chest pain. What are we going to do? We are going to get ready to do synchronized cardioversion. We're going to go to that cardioversion. We're going to try to use sedation if we can, because it's very uncomfortable. So we want to use sedation, and if we can, but the priority is going to be synchronized cardioversion. So let's talk about, just briefly, let's talk about your prioritization and thinking like a nurse. When you're thinking about tachycardia with a pulse, the priority, if you have unstable tachycardia, is going to be cardioversion. That said, what would you do first? I'm going to do some vagal maneuvers first. It's non-invasive, and I can do it sitting right at the bedside. You're gonna try to do some vagal maneuvers while you're getting everything else ready. So priority though is going to be a synchronized cardioversion. So if it is narrow complex, another thing that we'll consider is using adenosine. So adenosine is an IV medication that has a very short half-life, seconds of a half-life. It is given very rapid IV push. You see your dosages here. It's only going to be used if it's a narrow complex or tachycardia. Your first dose is that rapid IV push, and you follow with a normal saline flush. Why? Because the half-life is seconds. We can't take the risk of it just sitting in this vein down here. We got to get it to the heart. We need it back to the heart right now. So you push flush, it is fast, rapid as you can. Push flush, fast as you can. And then you start with a 6 milligram dose. These are the doses you need to know. 6 milligram dose. Second dose is going to be 12 milligrams. What is going to happen when you give your patient adenosine is that their heart is going to stop for a few seconds. And it is basically going to then reboot and hopefully slow down. A lot of times what they'll use adenosine for is so that they can see what that underlying rhythm is. When it's up over 170 and they can't, over 150 and they can't see what the underlying rhythm is, they'll give adenosine to slow it down so that they can see what that underlying rhythm is. Is it sinus, AFib, a flutter, what's going on here? It is going to make your patient feel like they're going to die, literally. Their heart is going from bim, 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 bam, 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 and they literally feel like they're going to die. It is called having a sense of impending doom, is the term that we use. When it happens, they have a sense of impending doom. something horrible has happened. This is not the way this is supposed to be. Something went terribly wrong and now I'm dying. That is literally how your patient feels. So guess what will make them feel better is if you tell them beforehand, just so you know, this medication is going to make you feel like you're going to die. Not from pain, but just an overwhelming sense of doom and gloom and that things are just bad is what you're going to feel. And so you educate your client and tell them, look, this is what's going to happen. I need you to understand that there's a pause, and when your heart starts beating again, you're going to feel better again. So that's, remember, it only has a couple second half-life. So that's as long as it's going to last. That's as long as that stopping lasts, because then it's gone. It's out. The half-life's over. It's been metabolized. It's out of the body. That's it. So keep that in mind. That's the big education need there. So I'm not going to talk about these antiarrhythmics right now because, like I said, we're going to talk about that with wide complex tachycardias in a minute. Right now, we're focusing on narrow complex tachycardias. So I'm just going to clear all my writing because it's gotten kind of busy over there. And I'm going to change colors because I want to. So, got your patient came in with a heart rate of 150, 180. We'll make it legit. So it's 180. You've got an IV. They don't need any oxygen. They're 97% on Rumare. You don't need to treat them with oxygen. You've got them on the monitor. You have checked a blood pressure. It's 120/80. They're sitting up laughing with their spouse about they can't believe they didn't know their heart rate was 180. That's going to tell me right here. I'm going to go ahead and do my assessment, but I have found that no, they are not having any of these symptoms. I can tell on the monitor it is a narrow complex tachycardia. So that's going to bring us down here. We're going to have our patient try some vagal maneuvers, try to bear down, try to get that back down to normal. If that doesn't work, we're going to use adenosine. We're going to go ahead and if it's regular, it's narrow complex, we're going to give this dose of adenosine over here. 6 milligrams rapid IV push, followed by flush. Don't forget the flush. Second dose, 12 milligrams. We did educate our patient first on how horrible they're going to feel for about 3 seconds. But it's going to seem like longer than that to them. After that has slowed it down. So what happens when it slows it down, even if it speeds back up, what it allows the cardiologist or the physician at the bedside to see, is this a sinus tachycardia? If it's a atrial fib or atrial flutter, remember, we're going to have to go back to some other treatments besides what we're going to do for just a sinus tachycardia, because that means that we've got some other things going on. So that's why they might want to slow it down to see what do we want to do to control that rate. It's going to help guide them. Beta blocker, calcium channel blocker, we're going to get that cardiologist on board to see what we need to do next. Now, we got somebody else coming in our next room. They've got a heart rate of 180. So we've done all this. Now this patient, we did have to put some oxygen on because their pulse ox was only 86% on room air. So we've got them on 3 liters nasal cannula. They're up to 95%. We've got their IV access and we've got a 12 lead going, but it's showing a narrow tachycardia with a pulse rate of 185. Now, unfortunately for this patient, their blood pressure is 70/40. Not good, not perfusing the kidneys or anything else that needs to perfuse. Because their blood pressure is so low, they're confused, they feel awful, they are dizzy, they are diaphoretic. So we are now going to go over here to, yes, they are those things. We are going to prepare to cardiovert. In the meantime, while I'm getting all my stuff together, we've talked to the physician, we're going to go ahead and sedate them. We're going to do all this. This is fast. This is all happening within 5 or 10 minutes, if that. We're moving fast. We're going to ask them to do some vagal maneuvers while we're on the move. Nothing, that's not helping those, so we're just going to keep on moving. It is, and so we're going to go ahead and cardiovert them. That was our priority. The priority is if you are not perfusing because your heart is going too fast, the priority is to get it back, slowed down, and get it in rhythm. So we now have it in rhythm. So, or let's say it didn't get back into the rhythm. If it didn't get back in rhythm, we can go over here to this box. We may need to increase the energy level for the cardioversion and try again, just like they did in that video. They went up to 200 joules before they got her back in rhythm. We may need to add an antiarrhythmic drug. But these are for wide complexes, so we're not going to use those for our narrow complex. But we always want an expert consultation to see what is going on. And always, always, always identify the underlying cause. If you don't know what caused it, you may just be spinning your wheels. You're just putting a Band-Aid on because you need to find the cause so that you can do the permanent fix. All right, so we talked about SVT briefly. So basically, tachycardia over 150, we're going to call it SVT because I don't have any idea what is happening right here. All right, like, is there a P wave? I don't know. Is that AFib, A flutter, sinus? No idea. We're going to call it SVT. So let's watch videos. Pretty fast.
This is a 4 liter also open. The 4 liter going as well. Yeah. Well, it's not taking his blood pressure. Oh, that's okay. All right, sounds good.
That's 6 milligrams.
Yep.
So this is back when we actually used
And
needles.
remember, you might feel that funny feeling in your heartbeat discuss once you get the medicine, okay?
Try to hold that so we don't stagnate it.
Just make sure.
So this is how we used to give it.
Where?
But you'll see him
Alright, sir.
That's okay, you can call your shot.
give it and then flush immediately behind it. You hear the patient.
You want to do it all at once because you want it to get there like a hammer day. So, don't not slow down. And what it does is causes the system and lets it resets and hopefully your underlying rate can take back over.
They're ready.
It may not work.
You hear the patient is like, whoo.
If she's tachycardia by that cause, it's a cardiac related issue, then it may fix it. But if she's tachycardia because she needs 15 liters of fluid, it may not work.
It worked.
What? Thank you for that.
Oh, thank God.
It'll pass. It'll pass. So it's what now? It's about 120 now.
All right, so let's just look at a few other things that we'll be able to recognize from our EKG strip. So Miss Stoic will be talking to you about acute coronary syndrome. And so looking at changes in our T wave, we may see, we may see an inverted T wave when there's ischemia present. So an upside down T wave. The other thing that we'll see is when we talk about MIs is at the STEMI, the ST elevation MI. So that's kind of what this looks like here. So basically, remember we talked about that isoelectric line. Let me erase. So remember we talked about the isoelectric line. It's going to be easier to see right here. So we've got our QRS, and S returns back to that isoelectric line. Remember that line that everything's kind of coming off of? So what we see in ST elevation, so if here is our isoelectric line, we've got our QR, and then that ST, it just goes right into that T wave. It doesn't return to that isoelectric line down here like we want it to. So this is elevated above the isoelectric line. So that's what we call ST elevation, and that is going to mean that there is infarction and injury happening. Another thing that we can look at with our T waves is the appearance. So with hyperkalemia, I know we've drilled into you since Unit 1 or since Miss Curley's fluid and electrolytes in 1 and 11 about hyperkalemia leading to EKG changes. So what we look for is a peaked T wave we will see with hyperkalemia. When you get up over 5.5, you can start seeing this peaked appearance of the T wave. Now, if you go on past about 6.5, what you're going to see is that might start to loosen back up a little bit, but you're going to see your QRS is widen out. When you get real severe hyperkalemia, you're going to see big changes in that QRS complex, widening out, and can progressively lead to asystole or ventricular fibrillation, which is a lethal arrhythmia, which we will talk about on your next video recording. The last thing we're going to talk about here is going to be PVCs, premature ventricular contractions. So what these look like is we've got some normal beats just trucking along, and then bam, bam, big giant ventricular beat. So that is a PVC. So PVCs is an impulse that starts in the ventricle and is conducted throughout the ventricles before a normal beat. So it can be caused by cardiac ischemia or infarction, in heart failure or tachycardia when there is a increased workload on the heart. We may see it then. We could see it in hypoxia, dig toxicity. We see an increase in PVCs. Hypoxia, I already said hypoxia, sorry, I went backwards. Acidosis and some electrolyte imbalances, and especially hypokalemia. Let's see. I just realized my video wasn't started. That's what got me off. So these PVCs, that's some of the causes. So this is going to be another one like the PACs, where your client might say that they feel their heart skip a beat. It's often worse at night. I've heard cardiologists tell me, though, that it's not really worse at night. It's that they're just laying there still at night, and so they feel them more frequently. So PVCs are usually not treated unless they are becoming more frequent, so more than 6 a minute, or if it is causing, or if it is impacting quality of life for the patient. So if the patient is, it's causing them anxiety, they're feeling their heartbeat all the time, it's keeping them up at night, then they may treat it with a beta blocker or amiodarone. So these are going to be just these big ventricular beats that aren't going along. They are not perfusive. So if you're counting a pulse, you would not count it as a perfusive beat. If this was a 6-second strip, I'm not going to count it out, it would be 30 because that's all the perfusive beats we have here. 1, 2, 3. So we don't count them because they're not perfusive beats. But you do, if you're labeling your strip, you would say like this one, you would say sinus rhythm with PVCs. So that is what those are. So let's do some practice strips. All right, so on my last recording, I kept wanting to zoom in, and then it occurred to me I could just pull this up as a Word document, and then I could zoom in. So that is what I've done because I am learning more every day. So let's look at number 6 in your rhythm strip reviews here. Let's look at all the pieces that we have. So is there a P wave for every QRS? And it looks like there is. This looks like it's a P wave. And we have a QRS for everywhere. We have, let's measure out our PR and QRS intervals. So let's see here. Here's the beginning of a P wave just before that line. And the beginning of our QRS just before that line there. So we've got 1, 2. It looks like our PR interval is just about 2. So it's a little bit, it's a little bit slower. I mean, a little bit shorter, so faster than what we usually have. Oh, all my lines moved. Sorry about that. But if you're tachycardic, this is all happening really fast. You're going to see some more narrow numbers. QRS, we've got 1, 2. So we got 0.08 for our QRS. Our QT interval will go from the beginning of our QRS complex to the end of our T wave. So this is going to be 5, 6, 7. So 0.28. Remember, please, you should have, if you haven't done it already, pause it and rewind it back, because you need to have already worked this on your own before you work it in here with me together. With every single strip, hit pause when we get to it, work it on your own, and then come into review and see how you did. So is it regular? It would march out. If we were going to march it out, it should march out pretty good. So it is regular. Let's look at our rate. Let's see, do we have any ticks on this? Let me turn off my pencil for a second so I can scroll. No. Well, there we go. Get my numbers back on the line. Okay, so we got 1 second. 2, 3, 4, 5. 1, 2, 3, 4, 6. 6 seconds. So let's count them up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. We're going to count this one because this line ends on the line, and we've got the tip of our QRS complex up here. Oh, now I forgot what I counted. 1, 2, 3, 4. 18. So our rate is, oh, it's right here. Let me change colors. It's 180. So even though it looks like we can see these P waves, because it is so fast, that still could be a flutter. That's the underlying rhythm there. So we're still going to call that SVT. So we've got a tachycardia. So what are we going to do about it? What's our action? What's the very first thing we're going to do? Assess our patient. We're going to see if we can figure out what the causes are. So typically, I will tell you, when that first block they've got to get them an IV, check if they're hypoxic, see what the causes are, get an EKG, get a monitor on them. Typically, those things we're assuming that we've already done all those things. So what's the first thing we're going to do is assess our patient and see if they are symptomatic. If they are symptomatic, priority is what? Cardioversion. If it's a narrow complex, then we can consider adenosine, but cardioversion is going to be the priority. Synchronize. What do we need to do to the defibrillator to cardiovert? What's the button we need to push? Sync button. We need to synchronize it so that it's going on just after the R wave. If they are not symptomatic and they're narrow complex, we're going to start with vagal maneuvers, and we are then going to consider using adenosine. What's the first dose of adenosine? 6 milligrams. Second dose. Anytime I'm pausing, just push pause if you need more time. 12 milligrams. It is going to be given rapid or slow? Rapid. Rapid IV push. All right. Let's go on to the next one. Number 7. Why does that look jacked up like that? I don't know why that looks like that. Let me see if I zoom out, if it makes it better. Oh, yep, it did. Okay, that was weird. Okay, so let's see here. That looks kind of squirmy wormy, but let's just look at the pieces of the puzzle. So we've got P wave for every QRS. All of our complexes are we've got the P, QRS, and T wave for all of them. Okay, so that's good. So we've got that part. Next up, let's measure out our PR and our QRS intervals. So our PR, let's go from the beginning of the P wave here, go from right here to the beginning of the QRS complex. We've got 1, 2, 3 squares. So we're going to go with 0.12 for our PR interval. Our QRS complex is going to come back to about right here. So we've got 1 to about 2.5. So about 0.10. Our QT interval going from the beginning of the QRS complex. Let's find a different one. I'm going to go with this one. Going from the beginning of the QRS complex to the end of the T wave. So we've got a T wave, even though it's like all, we're still going to use it. 1, 2, 3, 4, 5, 6, 7, 8. So that's going to make our QT interval 0.032. Remember, our normals for a PR interval are between 0.12 and 0.20. So this is good. QRS interval is less than or equal to 0.12. So this is good. Now let's check out our rate. It is, I'm not going to count out the little squares. We're going to go ahead and go with that. It's a 6-second strip. But just know that you need to, if you don't have the tick marks, count your squares. Okay. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 as our rate. So that makes our 13 QRS complexes. So that makes our rate 130. So what is our rhythm? We've got all our P waves. We're sinus tachycardia. We're going to assess our patient and see how they feel. That is what our priority is going to be. So I know that you guys who aren't used to looking at rhythm strips don't like seeing this baseline go like this, right? But remember, these are being traced from electrodes that are on somebody's skin. If somebody's moving around, it's going to mess with how smooth that looks. Sometimes when they're breathing and they're taking deep breaths, especially somebody that's very bony and doesn't have a lot of cushion between their ribs and where you've got those stickers, you're going to see that movement there. So don't let that throw you off. Still just look at it individually. Okay. Next up, what do we got? P waves? Anybody see P waves? Nope. So do we know what the PR interval is? Nope. We don't know. It's not applicable because we don't have a P wave to measure. What about QRSs? We can do that. We go. We got 2 little boxes between. So we got 0.08 QT interval. Do you know exactly where that T wave is? I do not. It is all squiggled up in the crazy P waves. So we're not sure about that either. So what is this rhythm? We've got disorganized chaos, disorganized disorganization. Let's look at the rate, 6-second strip. Oh, this one does have tick marks. Look, there's a tick mark right there. There. There's the corner one right there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Got a rate of 100. So we have AFib. It's a controlled rate. Good. So with AFib, we're going to treat, we're going to look at this patient may need to be cardioverted. We need to look at, have they been anticoagulated, or has this been going on for less than 48 hours? Otherwise, we've got to get that TEE, that transesophageal echocardiogram, to make sure there's no clot in that left atrial appendage before we cardiovert them. And remember to hit that sync button on the cardioversion machine. All right, next up. That looks weird, huh? That doesn't look like normal, like you like things to look. So let's check it out. I'm gonna change away from red. That just seems threatening. Okay, let's go with a nice green. Okay, so first up, are all the pieces here? Do you see P waves? Remember, if you haven't worked this out on your own, go ahead and pause it and work it yourself first before you go through it with me, because I want you to practice on your own as well. So we've got our P waves, QRS complexes, T waves. So that's a normal complex. All these complexes look the same. They've got that sinus P wave coming out of that SA node. They all look the same. So the first answer is yes. We do have a QRS and a P wave, all for all the complexes. Next up, we've got, do we have a normal PR interval and QRS complex? So let's see here. Here's the beginning of our P wave. End of our QRS complex. We've got 1, 2, 3, 4 for our PR interval. So that's going to make it 0.16. Oh, I'm not doing a good job here. Drawing numbers. Okay. Our QRS complex, we've got, actually, I don't like that. I think it's a little bit further over here that we're leaving the isoelectric line. Let me erase that. So I feel like I can see it better with this one. Here to here. So we're right. No, that's still the same. Okay. Yep, I was right. Okay. Sorry. If you doubt yourself, check yourself again. Okay. So QRS complex. We've got at the beginning, we've got the beginning of our QRS. Here's one that leaves right here. 1, 2, 3. Here. It's 0.12. So these are both good. They're both within normal limits. QT interval, let's just count from this one here. Looks like we got 5, 10 between the two. So that's going to be 0.40, which is fine. Let's count out our QRS complexes. 1, 2, 3, 4, 5, 6, 7. So we've got a rate of 70. So what do we have here? And we forgot to march it out. And it does march out. If we measure between the number of boxes between, or we can use calipers or the paper method to march it out. So it is regular. So we've got sinus rhythm. It's a normal sinus rhythm. All these little jiggly jigs are just where that patient's moving around. It's called artifact. It's just jiggly jigs. But what we can see on the underneath is all the pieces that we need. So don't get thrown off there. Okay. Ooh, Let's see, I'm gonna have to zoom out a little bit so we can see the whole guy. There we go. Okay, so what do we have here? We have, I'm gonna change colors again. I'm getting bored with my same old colors. I'll get pink. Does that, okay. So, where's the P wave? I don't know either. Which one's the T wave? I don't know that either. So we can't measure our PR interval. We can't measure our QT interval. But we can measure our QRS. Let's do that. We got that little bit we can do. Let's go from here to here. So we got 1, 2, 3 spaces. 1, 2. What's our rate? We got tick marks. Whoop, whoop. Up at the top, 3-second tick marks. So we got 1, 2, 3, 4, 5, 6, 7. The rate is 70. And what is the rhythm that has the sawtooth pattern? Atrial flutter. All right. So we're going to treat that the same way we do the AFib. Right now we've got a good rate. We've got a controlled rate, so hopefully our patient isn't too symptomatic, and we can investigate if there might be a clot present so that we could cardiovert if we need to, or do the TEE if we need to do that, put them on anticoagulants. Going to be a priority. Do they need ablation? Do they need rate control medications? And that's it. That is going to be our path of treatment. Right, next up, we have here, let's look. Do we have our P waves? We've got normal complexes. Got some normal complexes. Normal complexes over here too. If we march out just our normal complexes, these two to these two, and then compare that to these two, we're going to march out regularly with our normal complexes. So we're going to call those regular. We've got all of our pieces that we need for the regular complexes we have. So let's look at our measuring. Let's look at our PR intervals and QRS complexes. We've got here, 1, 2, 3, 4. Got a good normal 1.16. We got a QRS complex 1, 2, 0.08. And we got a QT interval of 10. So 0.40, also normal. So we're measuring from the beginning of the QRS to the end of the T wave for our QT interval. So that is going to be 0.40. Now, the rate. Let's look at our rate. We have here 1, 2, 3, 4, 5 QRS complexes. We are not going to count this guy right here. What's that guy called? You remember? It's a PVC. So we're going to not call him. Those are PVCs. They're not perfusive. So we're not going to count them because they're not causing a pulse. So we've got 1, 2, 3, 4, 5. So we've got a rate of 50. So we're going to call that sinus bradycardia with PVCs. That's what we've got there. Action-wise, we're going to assess our patient. They maybe my guess is somebody that had a heart rate of 50. Remember, we talked about typically between 50 and 60, we don't see symptomatic bradycardia. But we're going to assess and just check. We're also going to see if they're able to feel these PVCs and if they're making them feel bad. We're going to check and see what the causes could be. What kind of things do they take that could have led to an increase in PVC. So that's the big thing with PVCs. If you're having them every so often, you've been having them every so often, and they don't bother you, that's fine. If you're starting to have more and more and more PVCs, like you've gone from having 2 PVCs a minute to having 5 or 6, anything over 5 or 6, you want to call the physician, because they may want to look at doing an antiarrhythmic medication to treat those PVCs, because they are increasing in number and can lead to a cardiac arrhythmia if they get together with all their friends. So we want to keep them in a lower amount. So as long as the number of PVCs is low and it's not increasing. But if you see PVC number increasing, you need to call the physician and anticipate a antiarrhythmic to get on board to get those under control before your patient gets in trouble. And you know what's going to happen if you don't. Dun, 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 dun. You're going to put them, they may go into this, which is ventricular tachycardia, and is a lethal arrhythmia that can be pulseless, or possibly even this one here, which is VFib and is pulseless. So in our next recording, we are going to start talking about pulseless lethal rhythms and how to treat them, the process of going through advanced cardiac life support, and saving somebody's life using evidence-based practice. So I know that some of this information seems really fast. So, I mean, that is the benefit of this being recorded. You can continue to record, to rewind back and find the parts that you didn't understand. I encourage you to do that. Please be active in the discussion board, post questions, send me emails and ask me questions. We will be doing more rhythm practice in the learning activity. We will be also talking more about how to treat different arrhythmias. Look at your algorithms. You need to memorize your algorithms and learn how to use them. We'll have more algorithms to come in the next presentation. So you need to understand this content before you move on to the next content. So if you have areas that you feel like you didn't understand, go back and watch it again. Let me know if you have any questions, and I will see you all shortly.